Assalamualaikum and good day everyone. Alhamdulillah, we managed to have yet another slot of CME for the young doctors to help you all grasp the salient point for betterment of management of patient. Today we discuss on how a misdiagnosed, the number one cause of death in ectopic pregnancy, otherwise preventable. To illustrate better, let's start with the drama minggu ini. Okay, this is based on a real life scenario that happened. First presentation of this patient, she's an Indonesian lady presented with lower abdominal pain and she went to GP to sought treatment. UPT done positive but scan showed uterus was empty. She was discharged home and no TCA was given. Her second presentation was a week later, whereby she went to the same GP but this time with per-vaginal bleeding. UPT was repeated, it was weekly positive, no scan was done and she was told that she was actually having a failing pregnancy and that she is currently having her normal menses. Okay, her third presentation now, the pain that has come 1 week earlier has persisted, hence this unfortunate lady ride her motorbike and went for a traditional massage of the abdomen by Indonesian bidan deep in a plantation. In the middle of the massage, patient claimed that the pain was worsening and unbearable and she suddenly became unresponsive and pale. So, right after the bidan called the ambulance for help, as the area was deep in a plantation estate, the ambulance took some time to arrive at the scene. Upon arrival, the MA noted that the patient was very pale and there was no sign of life. She was then brought to the mortuary for postmortem and guess what? The postmortem findings, there was actually a ruptured tubal pregnancy with hemoperitoneum of 2.5 liter. What an unfortunate event, which actually a preventable death. Let's start with ectopic pregnancy. What is ectopic pregnancy? It is any pregnancy implanted outside of the endometrial cavity. The majority of ectopic pregnancy occurs in the fallopian tube, but other possible sites are the cervix, ovary, interstitial, and also abdominal pregnancy. The incidence is approximately 11 per 1,000 pregnancy, which is actually very low. Unfortunately, women still die from ectopic pregnancy. The diagnosis of ectopic pregnancy is based upon a combination of careful history taking, thorough examination, findings on the transvaginal ultrasound, plus minus measurement of serum quantitative human chorionic gonadotrophin. Presentation of ectopic pregnancy. It can be any per-vaginal bleeding or abdominal pain which occur during her first trimester. It can be also asymptomatic, but clinical manifestation of ectopic pregnancy typically appears 6 to 8 weeks after the last normal period, but may occur later, especially if the pregnancy is extrauterine site other than the fallopian tube. For example, interstitial pregnancy usually occur within 10 to 13 weeks. The symptoms suggestive of rupture should be noted. This includes severe or persistent abdominal pain or symptoms suggestive of ongoing blood loss. For example, feeling faint or loss of consciousness. Based upon the concern about the risk of rupture at the time or after presentation, clinicians, that means you guys, should consider ectopic pregnancy as a diagnosis in any woman of reproductive age with vaginal bleeding or abdominal pain who has the following characteristic. 1. She's pregnant but does not have a confirmed intrauterine pregnancy, that means the uterus is empty. Second, pregnancy status is uncertain, particularly if amenorrhea of more than 4 weeks preceded the current vaginal bleeding. Number 3, in rare cases, a woman who presents with hemodynamic instability and an acute abdomen that is not explained by another diagnosis. Okay, Let's move on. Who are at risk developing ectopic pregnancy? The major cause of ectopic pregnancy is disruption of normal tubal anatomy. It makes worse if there is also accompanied by functional impairment, for example, in a case of damaged ciliary activities. Those in red are the risk factors. Okay. This table shows relative risk factor for ectopic pregnancy, which can be divided into high, moderate and low. Okay, for the high risk, if it presents during your clucking in the history, if the patient have had a tubal sterilization, BTL done, history of insertion of IUCD, history of previous ectopic pregnancy or PID, pelvic inflammatory disease, they have the higher risk of having ectopic pregnancy. Second, moderate risk, those who are smoker, having more than one partner, history of infertility or history of chlamydia infection, past or current present infection. Low risk factors, having had douching regularly, age greater than 35 or less than 18, and also patient who underwent IVF. The classic symptoms of ectopic pregnancy are abdominal pain and per-vaginal bleeding, but we must not forget the differential that may also have similar presentation. For per-vaginal bleeding in early pregnancy, you have to think of physiological cause. For example, it is believed to be related to implantation. It could be also patient presenting with spontaneous abortion, gestational trophoblastic disease, or actually is from a cervical, vaginal or uterine pathology, and also it could be due to subchorionic hematoma. As for abdominal pain, you have to think of urinary tract infection, kidney stone, appendicitis, ruptured cyst, ovarian torsion, and also pelvic inflammatory disease. For diagnostic evaluation, step 1, we need to confirm the pregnancy and ectopic pregnancy symptoms. Okay, the most important thing here is a menstrual history for estimation of the gestational age. Risk factor of ectopic pregnancy should be elicited. Remember the table earlier. The medical and surgical history should be reviewed since this may impact the treatment. Focus should be on the past obstetric history, past surgical history, especially pelvic surgery, and medical comorbidities, because it has potential contraindication for further management later. Human chorionic gonadotrophin, HCG. Measurement of HCG is performed initially to diagnose pregnancy. Usually it is done by urine pregnancy test, UPT, then followed by serially to assess for ectopic pregnancy, which we usually repeat 48 hours serially. The diagnosis of ectopic pregnancy can be made after a single measurement of HCG in combination of transvaginal ultrasound, TVS. Step 2. Evaluate hemodynamic stability. First, physical examination. Vital signs should be measured and hemodynamic stability assessed. Abdominal examination could be unremarkable or may reveal lower abdominal tenderness. If ruptured with significant bleeding, distended and diffuse abdomen or localized tenderness to palpation and or rebound tenderness could be present. Speculum examination to confirm bleeding is actually from the uterus, and also to quantify bleeding volume which collected in the vagina. Bimanual examination could be unremarkable in unruptured scar. Cervical motion, annexal and also abdominal tenderness could be present in case of ruptured ectopic pregnancy. Palpation of annexa with only small degree of pressure as excessive pressure may actually rupture an ectopic pregnancy. Fast ultrasound. Focus assessment with sonography for trauma (FAST) is part of initial assessment and resuscitation of patient. Patient is not hemodynamically stable. Evaluated with abdominal ultrasound to assess quickly for intraperitoneal hemorrhage. Identification of intraperitoneal bleeding in a woman of reproductive age should be considered a potential ruptured ectopic pregnancy until proven otherwise. Other investigation: transvaginal ultrasound, FBC to evaluate anemia, GXM to stand by for any surgical intervention, coagulation profile to see if there's any derangement in a massive hemorrhage, and also renal profile and liver function test as a pre-treatment test if patient were to treat by methotrexate. Step 3. Assessing pregnancy location. TVS, transvaginal, is the most useful imaging test for determining the location of pregnancy. Should be performed by a clinician with expertise in gynecology ultrasound and with the evaluation of ectopic pregnancy. TVS alone can exclude or diagnose an ectopic pregnancy only if one of the following findings is present. Findings of diagnostic of an intrauterine pregnancy. That means if there is intrauterine pregnancy, you should be able to see a gestational sac with a yolk sac or embryo. However, in women who conceive with ovulation induction or in vitro fertility (IVF), heterotopic pregnancy may rarely occur. Finding of diagnostic of pregnancy at an ectopic site: gestational sac with a yolk sac or embryo with or without heartbeat. Step 4. Follow with HCG and ultrasound to confirm or exclude ectopic pregnancy. In a normal pattern of HCG in pregnancy, usually we expect a rise of 66% in every 48 hours in a normal viable intrauterine pregnancy. A serial HCG is a measurement of serum quantitative HCG which performed initially, and as for follow-up, it will be repeated every 48 hours to determine whether the increase is consistent with an abnormal pregnancy. A single HCG measurement alone cannot confirm the diagnosis of ectopic or normal pregnancy. Beta-HCG discriminative level is the serum HCG level above which a gestational sac should be visualized by TVS if an intrauterine pregnancy is present. In HTA, our discriminatory zone is a serum HCG level more than 1,500. The discriminatory zone is higher for transabdominal ultrasound, which approximately when your beta-HCG level is about 3,500. in international unit per milliliter. Beta-HCG discriminative level is the serum HCG level above which a gestational sac should be visualized by TVS if an intrauterine pregnancy is present. In HTA, our discriminatory zone is a serum HCG level more than 1,500. The discriminatory zone is higher for transabdominal ultrasound, which approximately when your beta-HCG level is about 3,500 in international unit per milliliter. Setting a discriminative level to 3,500 actually minimize risk of disrupting a viable intrauterine pregnancy, but increase risk of delaying a diagnosis of ectopic pregnancy. If patient is stable and no pain but beta-HCG is high, we would subject patient for beta-HCG surveillance but as an inpatient as a safer option. HCG is rising normally. Patient should be evaluated with TVS. Intrauterine pregnancy or ectopic pregnancy can be diagnosed via TVS. HCG is rising but not normally. The lack of a normal rise in HCG across 3 measurements every 48 hours is consistent with an abnormal pregnancy. Could it be ectopic gestation or intrauterine pregnancy that will ultimately abort? Beta-HCG is decreasing. Usually a decreasing HCG is most consistent with a failing pregnancy. The The other test that you can do to diagnose ectopic pregnancy, which we shall seldom do, which is progesterone level. Serum progesterone concentration are higher in a viable intrauterine pregnancy versus ectopic pregnancy or a failing intrauterine pregnancy. The predictive value of a low serum progesterone suggestive non-viable pregnancy. Measurement of serum progesterone may be useful in a patient with abdominal pain and bleeding and who has a serum HCG level below that expected for her gestational age. However, the definition of low progesterone is unclear. Okay, this graphic shows the location of ectopic pregnancy, and you can see majority occurs in the fallopian tube and usually 70% occurs in the umbula region. Let's move on to the management of ectopic pregnancy. Traditionally, we used to do surgery for the management of ectopic pregnancy, but now we are moving on to the pharmacological management first, which is methotrexate. This is a methotrexate. What is methotrexate? Methotrexate is a folic acid antagonist. It is widely used for treatment of neoplasia, severe psoriasis, and rheumatoid arthritis. How it works? It inhibits DNA synthesis and cell reproduction, primarily in actively proliferating cells such as malignant cells, trophoblasts, and fetal cells. MTX is rapidly cleared by the kidneys with 90% of an intravenous dose excreted unchanged within 24 hours of administration. As for the treatment of ectopic pregnancy, it uses intermediate MTX dose whereby we give 50 mg per meter square of body surface. Okay. Not everyone is suitable for MTX. The indication of MTX is if the patient is hemodynamically stable, there's no contraindication to MTX therapy, serum beta HCG concentration less than 5,000 milli-international unit, there is no fetal cardiac activity detected on transvaginal ultrasound, willing and able to attend post-treatment follow-up appointments, and with access to emergency medical services within a reasonable time frame in case of a ruptured fallopian tube. Ectopic mass size less than 3 to 4 cm is also commonly used as a patient selection criterion. However, this has not been confirmed as a predictor of successful treatment. What are the contraindications for MTX? Some women are not appropriate candidates for MTX therapy and should be managed surgically. Usually, these are for those who desired viable intrauterine pregnancy. In case of heterotopic pregnancy, you have an intrauterine pregnancy as well as extrauterine pregnancy, so they are not suitable for MTX. A case of ruptured ectopic pregnancy, patient with clinically important abnormalities in baseline hematologic, renal, and hepatic laboratory values, immunodeficiency, active pulmonary disease such as tuberculosis or peptic ulcer disease. The toxicity of MTX is enhanced. Hypersensitivity to MTX, breastfeeding mother. MTX is excreted via kidney. We know that from the earlier slide. Therefore, women with kidney disease, a single dose of MTX can lead to death or severe complication. For example, bone marrow suppression, acute respiratory distress, or bowel ischemia. Kidney and bowel disease may slow down metabolism of methotrexate, which may result in pancytopenia and skin and also mucus disorder. How do we give MTX? MTX can be given systematically through intravenously, intramuscularly, or orally, or by direct local injection into the ectopic pregnancy sac transvaginally or laparoscopically. But the most common route for treatment for tubal pregnancy is via intramuscular administration. What's the protocol? After the injection of MTX on day 4 and day 7, a serum hCG concentration is drawn. If the decrease in hCG between day 4 and day 7 is less than 15%, a second dose of MTX is administered. It is common to observe an increase in hCG level from day 1 through day 4, and this should not cause concern, as this could be due to continued hCG production by syncytial trophoblasts despite cessation of production by cytotrophoblasts. Pain after treatment. Patient would encounter a mild to moderate abdominal pain of short duration, probably 1 to 2 days at 6 to 7 days after receiving the MTX is common. The pain may be due to tubal abortion or tubal distension from hematoma formation and can usually be controlled with NSAIDs. However, bear in mind, patients need to be assessed first. We move on to surgical management. The indication for surgical therapy include patient which is hemodynamically unstable, suspect of rupture, contraindication for MTX therapy, or failed medical therapy. In a patient who is hemodynamically unstable, we will go in for an emergency surgery, whereby patient who presented with sign and symptom of impending or ongoing rupture of ectopic mass, example, pelvic or abdominal pain or evidence of intraperitoneal bleeding which suggestive of rupture. Indication for a concurrent surgical procedure. In a case whereby patient desire for sterilization, we will go in for an ectopic pregnancy with unilateral self-injectomy for the ectopic, followed by the other contralateral sterilization. We did a tubal ligation on the other side. In a case of patient who likely going for an IVF pregnancy, in a planned IVF pregnancy for future, it is known that removal of the hydrosulfings increase the likelihood of successful in vitro fertilization. This is the illustration. The picture shows how ectopic pregnancy looks like from a laparoscopic surgery. On the left shows a large tubal pregnancy. On the right picture shows interstitial pregnancy. And on the surgeon's hand shows a self-injectomy done with an intact ectopic pregnancy. Surgical planning, whether you want to proceed with self-phalangostomy versus self-injectomy, you want to go in laparoscopically or laparotomy. Self-injectomy is a standard procedure if the condition of the tube with the ectopic gestation is damaged, bleeding is uncontrolled, or the gestation appears too large to remove with self-phalangostomy. Self-injectomy appears to be associated with a reduced risk of ovarian cancer, in this case, a serous carcinoma of ovary. Advantage of self-phalangostomy, however, is the preservation of the tube for potential future fertility because we do not remove the fallopian tube. Laparoscopy versus laparotomy. Now we are moving on from laparotomy and we are focusing on laparoscopy surgery, which is the standard surgical approach for ectopic pregnancy. However, for patients with acute bleeding, some surgeon prefers laparotomy. Surgical approach should be made by the surgeon. with consultation from the anesthesiologist by taking into consideration the clinical status of the patient. Commonest question raised by couple who has had history of ectopic pregnancy would be, can I get pregnant again? What possibility of recurrent ectopic pregnancy? Well, the answer is, studies have shown that up till 90% will achieve a subsequent intrauterine pregnancy. How about recurrent ectopic pregnancy? The incidence of a recurrent ectopic pregnancy is approximately 15%. If we divide it further, recurrent ectopic pregnancy after a surgical treatment, which is salpingostomy versus salpingectomy, are similar. Ectopic pregnancy after methotrexate treatment is range between 10 to 20%. It is important to be aware of this scenario as you may encounter ectopic pregnancy not just in ONG department, ONG posting. You may also manage this patient in the future in emergency department or even in klinik kesihatan. Well, good luck. Thank you.